We'd like to thank SAGES for the opportunity to present our data here today on evaluating readmissions following laparoscopic cholecystectomy in the state of New York. My name is Maria Altieri, and I'm an assistant professor at East Carolina University, Brody School of Medicine. We have nothing to disclose. Gallstone disease is widely prevalent, affecting approximately 20 million people within the United States. Of those with gallstones, 20% are symptomatic. Due to this prevalence, laparoscopic cholecystectomy has become one of the most commonly performed procedures, with approximately 700,000 procedures performed per year. Laparoscopic cholecystectomy is now the standard of care for most gallbladder disease and is very safe. Despite the overall low mortality and our growing experience, it is not without complications. Hospital readmission constitutes an important component of associated cost of a disease and contribute a significant burden to healthcare. A large majority of studies evaluating readmissions following laparoscopic cholecystectomy consist of either single-center studies or are limited to outpatient setting, and thus can underestimate the actual incidence of readmission. The purpose of this study is to examine the true rate and reasons for readmissions following laparoscopic cholecystectomy using a large longitudinal database. The New York Statewide Planning and Research Collaborative System was used to evaluate for all laparoscopic cholecystectomies. SPARCS is a comprehensive data reporting system that collects all patient-level data from every Article 28 facility in the state of New York. Procedures were identified between 2000 to 2018 with the use of an ICD-9, ICD-10, and CPT codes for inpatient and outpatient surgeries. Patients with age less than 18, duplicate records, those with missing identifier, and in-hospital deaths were excluded from the analysis. Due to the presence of a unique identifier, patients with readmission to any New York hospital were evaluated. Planned versus unplanned readmission rates were compared. 30-day unplanned readmissions was defined as those with an emergency department visit record and admission type as urgent or emergent within 30 days of index procedure. Emergency department visits were only counted as readmissions if the visit led to a subsequent admission. In addition, further information about the patient readmissions was collected, including location of readmission, number of readmissions, and timing of readmissions. Preoperative, intraoperative, and postoperative variables were recorded. Following univariate analysis, multivariable logistic regression model was used to identify risk factors for unplanned readmissions after an accounting for baseline characteristic comorbidities and complications. There were 591,627 patients who underwent laparoscopic cholecystectomy during the study time period. Overall 30-day readmission rate was 4.94%, and the majority of these were unplanned, as the unplanned 30-day readmission rate was 4.58%. The top 5 reasons for unplanned readmissions can be seen on the graph on the right. Patient characteristics for patients with readmissions is described in Table 1. There was statistically significant difference in terms of gender, age, race, and insurance. Other variables that were statistically significant between patients with planned readmission versus unplanned readmissions was whether the procedure was performed in an inpatient versus outpatient setting, whether the procedure was urgent versus elective, also the primary diagnosis type for the procedure, length of stay for the primary procedure, whether the patient had any comorbidity or any complication. The results of the multivariate regression analysis are shown here after taking into account for all significant factors based on the univariate analysis. Female patients were less likely to have 30-day unplanned readmissions. Patients older than 65 or younger than 29 were more likely to have 30-day unplanned readmissions. Insurance status was also significant, as patients with Medicaid or Medicare were more likely to have unplanned readmissions compared to patients with commercial insurance. In addition, variables such as Black race, presence of any comorbidity, or postoperative complications and prolonged initial hospital length of stay were more likely to have subsequent readmissions. This data shows that the 30-day readmission following laparoscopic cholecystectomy is relatively low, less than 5%, with the majority of readmissions though being unplanned. However, given that there are up to 700,000 procedures performed in the United States alone, this represents about 35,000 readmissions. The readmission happened mostly within the first postoperative week, and about 20% of those readmitted were admitted to another hospital. The most common reason for unplanned readmission was associated with complications of the procedure or medical care. By identifying certain risk groups, unplanned readmissions may be prevented.